Hi, it's Christina with the Sisyphean Journal. I already covered one death for today, September 7th, a case where an abortion tubal ligation combination surgery costs the life of a young woman who wasn't even pregnant in the first place. Today, we are going to look at the penultimate death that I know of attributed to Moshe Hachamovitch's bad abortion clinic management. In this case, he had a very personal hand in it. She was actively his patient. So Tanya Williamson was 35 years old when she went to Moshe Hachamovitch's New York abortion facility on September 6, 1996 for an early second trimester abortion. She's referred to as patient A in medical board documents. So Hachamovitch estimated that she was about 14 weeks pregnant. He instructed her to return the next day for her abortion. Okay, so he inserted the little seaweed sticks, the laminaria, to expand her cervix to do the abortion. So the next day, she returned for the abortion. And there was a certified registered nurse anesthetist who gave her Valium at 11 a.m. Why they gave her Valium so early when they weren't starting the abortion until 1:50 p.m., I do not know. But the CRNA administered 150 milligrams of Brevital, and Hachamovitch did the abortion. Now, the medical board notes 150 milligrams of Brevital causes loss of consciousness and potentially decreases the patient's respiratory rate and blood pressure. The amount of Brevital administered to this patient would cause respiratory depression for approximately 30 minutes. The majority of that time, patient A was in the recovery room. The level of respiratory depression is tied to the amount of stimulation of the patient. Surgery is a very strong stimulus. Once that is removed, the respiratory depression increases. Okay, so basically, she might be breathing just fine when you're in there with instruments doing things to her, but when you stop, her breathing is going to slow down, and she is in danger. You have to keep an eye on her very closely for at least 30 minutes. Now, the board noted that Tanya was still completely unresponsive from the effects of anesthesia when she was moved to the recovery room. Staff noted her pulse and oxygen saturation, then removed the pulse oximeter. And you know that. They clip it on your finger when you go to the doctor's office. That monitors your pulse, and it monitors how much oxygen is in your blood. They just took it off. Now, after 5 minutes in recovery, Tanya's blood pressure was 96/80, which is low, and her pulse was 68, which was within normal limits. But at 2:10 p.m., 10 minutes after she was brought into the recovery room, Tanya's blood pressure had fallen to 60/40, and her pulse to 52, and her respirations were shallow. Now, such a sharp fall in blood pressure is an alarming sign that the patient may be going into shock or suffering other life-threatening problems. And the falling blood pressure is especially alarming in combination with the shallow breathing. A minute later, 2:11 p.m., Tanya's pulse was noted as thready, which means that it was weak and erratic, and her blood pressure was so low that it could not be measured with the blood pressure cuff. The medical board noted, at this point, a patient without an obtainable blood pressure and a barely palpable pulse was functionally in cardiac arrest. Respondent was notified of the problem with patient A at approximately 2:15 p.m. So there was 4 minutes between noticing that she was in really bad shape and somebody telling Hachamovitch. But it's not like he exactly leaped into action. Now, he did examine her in recovery and start a new IV with D5W and ephedrine, and told the recovery room nurse to do CPR and told somebody else to call emergency medical services. They arrived at 2:41 to find Tanya blue and unresponsive with no pulse or breathing or fixed pupils. They took her vital signs, attached a cardiac monitor, and properly placed a breathing tube to get oxygen into Tanya's lungs. And they hooked up Hachamovitch's bag valve mask, that thing where they squeeze like this. You've seen them do that on TV. But they found out it was broken. It wasn't working. So they had to get theirs out. Now, the medical board said, quote, when respondent arrived in the recovery room, he should have immediately ascertained the patient's pulse, blood pressure, and if there was vaginal bleeding. This should have taken between 20 seconds and, at the outside, 2 to 3 minutes. He should have realized that the patient was in cardiac arrest and started ACLS, advanced cardiac life support. In other words, professional grade life support. This is something that a paramedic can do, a nurse can do, a doctor can do. He didn't. Okay. The cause of the arrest was not relevant at that point. The immediate treatment was the same. Given the clinical picture of this patient at 2:15 p.m. when respondent was called to the recovery room, EMS should have been called immediately and the patient intubated. That's they put in the breathing tube. Even if patient A were only in a near arrest situation, respondent should have immediately called EMS and instituted the rest of ACLS protocol. Advanced cardiac life support consists of immediately call to EMS for transfer to hospital, intubation, EKG monitoring so that if the patient requires defibrillation, the rhythm and appropriate ACLS drugs are known. This patient's condition had to be treated in a hospital setting. The sooner the patient were to get to the hospital, the better her chance of survival. Now, despite the fact that Hachamovitch had the equipment to put a breathing tube in, she was being given oxygen with a broken face mask. There was no note that Hachamovitch had even inserted an airway, which is a small plastic device that an EMT can put in that keeps the patient's tongue from blocking the airflow and keeps the patient's airway in a good position. And though Hachamovitch had additional necessary drugs on hand to help restore cardiac function, he did not administer them. He had an EKG machine, but never hooked it up. As the medical board put it, such a failure deviated from accepted medical standards. They further said, a physician who performs surgical procedures, i.e. abortion under general anesthesia in freestanding outpatient facilities, has an obligation to recognize when a patient is in cardiac arrest and to know how to resuscitate the patient. Respondent did not recognize that patient A was in cardiac arrest. Respondent did not carry out generally recognized resuscitation measures in this patient. And in spite of the medic's best efforts, Tanya died that day. They were unable to bring her back. Now, on the day that Tanya died, Hachamovitch had one RN in the recovery room, along with a medical assistant, a sonographer, and a receptionist from the front who would go into recovery to help when they were busy. The sonographer was not trained to observe patients recovering from anesthesia, and the receptionist had taken a medical secretary course, but she did not have any training in caring for patients recovering from anesthesia. At the time Tanya was brought to the recovery room, there were 9 other patients in the room, and another one was brought in a few minutes after Tanya. And of the 9 patients already in the recovery room, one of them was shaking and almost convulsing. So that is taking the attention of the RN, the only trained person in the room. But Hachamovitch is off starting another abortion with his nurse anesthetist off doing the other abortion with him. Nobody is in there making sure that the other 10 patients are safe while the nurse is caring for the shaking patient who probably needed care. So, the board noted that Hachamovitch's recovery room was not sufficiently staffed to adequately monitor the patients. And they noted that respondent's medical record did not accurately reflect the care and treatment provided to patient A. So, the medical board slammed Hachamovitch for multiple violations of standards of care in how patients were monitored and cared for after general anesthesia, the lack of training in the staff, lack of adequate equipment, and failing to use what little equipment he did have. The board suspended Hachamovitch's license and added probationary requirements that he had to be supervised by an anesthesiologist who had no conflict of interest, that Hachamovitch had to maintain advanced cardiac life support certification, and have at least one staff in recovery who was ACLS certified. Now, Tanya was neither the first nor the last woman to die because Hachamovitch just did not know how to run a safe abortion clinic. Safe for the women pro-lifers, the abortion clinic's not supposed to be safe for the babies. So, On January 22nd of 1986, so a little over 10 years before Tanya's death, Luz Rodriguez died after an incomplete abortion perpetrated at Hachamovitch's Bronx clinic. Then, in October of 1990, Christina Goswine died while Hachamovitch was doing emergency post-abortion surgery in his office instead of in a hospital. Guy just clearly had poor judgment. On March 2nd of 1994, Jamie Garcia died of sepsis after an abortion performed at one of Hachamovitch's clinics in Texas. On February 17th of 1995, Lisa Bardsley was sent home to bleed to death after an abortion at a Hachamovitch clinic in Arizona. Then we had Tanya dying on September 7th of 1996. And then, less than 2 years later, April 17th of 1998, Lou Ann Herron bled to death in a Hachamovitch clinic under circumstances so appalling that both the abortionist and the recovery room nurse were convicted of manslaughter. And it was another circumstance of just slipshod monitoring and recovery, whatever. So, clearly the legalization fairy just somehow missed Moshe Hachamovitch and did not sprinkle the magic safety dust on him.